Well, good morning, everybody, and thank you very much for logging on. We are very pleased to have a presentation today from the hospital grounds at Concord Hospital. So this is really at the grassroots, as it were, in a laboratory that's measuring respiratory function, which is as I said, right at the grassroots of why we do what we do to prevent respiratory and, of course, cardiovascular illnesses. I'm here to introduce Tanya Badal, who's going to talk a little bit about herself just briefly in the beginning to let you know about herself and why she's doing this project. And I'll leave it to her to explain it. What I do want you to do, though, when you've logged on now, is to add all the names of the people who are with you. We need to have a register of people who are actually sitting in with you at the site you're at, so that we can allocate them continuing medical education points. So if you could please do that when you're typing in, from now on, every time you log on, can you please say who else is there with you? Not just the site, but who the actual people are. This is for your own benefits. So without much ado, I'm going to introduce Tanya and her study about early COPD, a study that's very dear to my heart as well. Thank you. Thank you, Tanya.
Thank you, Renee. Hello, everyone. So today I'll be talking about the early COPD in smokers study. And just as a small little snippet about myself, I was a medicinal chemist a couple years ago and decided to move into clinical research. And that's when I stumbled upon this study that I found very interesting. So this study is a first-line treatment for smokers at risk of developing COPD. And it's also the world first trial for smokers aiming to reduce any kind of lung disease that develops from smoking. And this is done by detecting whether they are going to start or going to potentially have some kind of lung disease. And so the rationale for this study is that smokers experience an increased rate of lung function decline, and FEV1, which is obtained from spirometry, is poorly reflective of this decline, mainly because it requires about 50% of the terminal bronchioles, which are in your smaller airways on the periphery of your lungs. And these need to be lost before we have the FEV1 becoming abnormal. Okay, so FEV1 is a forced expiratory volume in the first second, and the maneuver is when you take a deep breath in and blast out as quickly and as forcefully as you can in order to see if there's any kind of obstruction or constriction in the airways. Now, another reason why this study is important is that airway inflammation and mechanical processes have also been found to cause airway injury. And this is shown when the lung ages relatively quicker than it should, that there's defective repair of airway injury and repeated airway injury of inflamed airways during opening and closing of these small airways on the periphery of your lung. And that can happen at any time, either resting breathing or tidal breathing. Now, for the gist of the rationale is that COPD is a second leading cause of avoidable hospital admissions, which causes quite a lot of burden on the healthcare systems. And 1 in 7 Australians are directly related or affected by COPD. Now, prevention of mechanotrauma, which is that breathing in and out of inflamed airways, could be reduced by using a bronchodilator, and this is just to avoid alveolar destruction, which is apparent in emphysema and COPD. The 2 questions that are addressed in this study include healthy smokers and their normal spirometry. Do these tests of small airway function identify individuals that are at risk of developing COPD? And does this affect their decline in FEV1? Again, this is a measure that we obtain from spirometry. So another question is, does this, using a bronchodilator, reduce the rate of this FEV1 decline in healthy smokers? And to see if we can use indices from multiple breath nitrogen washout, which gives us another, an image of what the small airways function looks like in these normal patients. So in order to assess these questions, the primary outcomes are a result of using a dual long-acting bronchodilator for 1 year. The primary outcome is looking at this FEV1 decline on active study treatment or placebo. Now, for normal or never smokers, a healthy rate of decline of FEV1 is about 30 mils per year, whereas a smoker would mainly have a 60 mil reduction over time, and especially in this age range of 25 to 55 years of age. So it's an increase, it's a double the decrease of the FEV1 that is exhibited in normal never smokers. Now the secondary outcome includes change from baseline in small airway function, and this is looked at with the MBNW test, which is the multiple breath nitrogen washout, and a couple other lung function tests, including the breathlessness, cough, and sputum scale, which is an idea of how the symptoms are impacting on these participants' lives. So the study is double-blinded, randomized, and placebo-controlled, and we have the two study arms of placebo or actual investigative so the actual study drug or the placebo over 12 months. And we're estimating to screen about 280 smokers with a normal FEV1 to get about 150 people recruited into the study. Now we do realize that there could be a 10% dropout rate and possibly 15% smoking cessation, which I will get into later. And we're hoping to now get about 50 participants per study arm, including the placebo and the actual study product. So the study sites include the Woolcock Institute of Medical Research, Blacktown Hospital, Concord Hospital, which we're at today, and Campbelltown Hospital. So here I've got, do I have an indicator? Okay, so here we've got the investigative product, and it's unlabeled, as it is usually in all clinical trials, and that's just so that there isn't a way to differentiate between a placebo or a actual product. So the subjects will be randomized, and they'll receive 1 inhalation dose daily. And this is umeclidinium bromide with vilanterol, which has been on the market for about 6 years now and used worldwide. The only reason why we have this clinical trial is because it's a product that's being used other than for its intended use. It's used for participants that already have COPD, or people that already have COPD. Whereas in this study, we're looking at healthy smokers and trying to keep these airways open in order to see if it prevents any kind of trauma or delays the onset of smoking-related illnesses. So drug adherence is assessed by the return of the devices, and you can see that there is a counter on the front of that device, which counts backwards, so 30, 29, 28, depending on how many doses that the participant has used. And their adherence is also encouraged during monthly phone calls. Now, for this study, any medications that are prescribed for any kind of medical condition that this participant already has are permitted. The only thing that is excluded are SABA, which is a rescue similar to Ventolin that may be used as required. So just to go over some lung function testing, small airway function is not done at many clinical or respiratory clinics. It's mainly research-based at the moment because, as I said, we're trying to find whether small airway function is an indicator of whether these participants are going to have an onset of smoking-related illnesses. And one way of doing that is using the forced oscillometry technique, which is also called the FOT. And with this test, you can see in this photo, we've got a patient with a nose peg on to make sure that the air is only being moved in and out through the mouth. And we send an air wave down into the lungs, which you can't feel, but it kind of gives a bit of a wiggle and gives you two different types of indices, which is the resistance and the reactance. Now, the resistance gives us an idea of the airway diameter, and that's how easily oxygen, or just the gas in general, is able to move in and out of the airways, whereas the reactance gives us the elastic properties of the lungs, and that will tell us how fixed or how floppy these airways may be. Another test is the multiple breath nitrogen washout. And this is just a readout that we get from the test. And we look at gas mixing and the convection and diffusion. Now, convection is the movement of a gas through a large portion movement through an airway. And we refer to that as the S-cond with this test. So we're looking at the conductive airways. And then when we look at diffusion, we're looking at the alveolar sacs and how well a gas can diffuse across that membrane into the bloodstream. And that gives us the S-ASN indice. And we also have the LCI, and that's the lung clearance index, and it tells us how long does it take for a participant to wash out a particular gas. Now, in this readout, we can see that we start at a relatively high concentration of gas, and it decreases over time. And the longer it takes for this to plateau gives us an idea of how much gas, what's the word?
Retained.
Yeah, so gas trapping, sorry, that's what the term is. So if there's a lot of gas trapping, this means that there can be some areas of the lungs that aren't being used as readily, gases aren't able to flow into it, and again, they wouldn't be very effective at transferring oxygen into the bloodstream. And this obviously is a direct cause or direct problem associated with smoking, any kind of emphysema where the lung is actually starting to deteriorate and unable to use to do its normal function. Now, spirometry, as I explained earlier, is looking at the obstruction and constriction, and we do this in a pre and post, meaning we have normal testing, and then we give them a bronchodilator to see if there's a change. And this gives us an idea of whether their obstruction or constriction is reversible. Now, a DLCO is the transfer factor of carbon monoxide, and this tells us how easily a gas can transfer from the oxygen entering your lungs across that membrane and into the bloodstream. And finally, we have the lung volumes, which gives us an idea of how large the lungs are. And with COPD, we can see that sometimes participants are hyperinflated, which means that they aren't able to completely get the gas out of their lungs, which again is a result from the gas trapping, holding on to too much air and not properly being able to breathe out all that gas. And those last three tests are all done in a box and across all different respiratory clinics. Now, just to briefly go over the eligibility criteria, we are looking for participants that are aged 25 to 55 years of age and that are continuing and current smokers with a 10-year pack year of smoking history. And we look at their spirometry results, which is what we get from their screening visit, and we're looking for relatively normal participants with normal lung function. So another indice we're looking for someone with abnormal washout, and this is that gas trapping when you're breathing out completely to try to get that plateau like I showed in the previous slide, and it gives us an idea of whether there's any constriction or issues at the acinar airways, which are those alveolar sacs, or the longer or the bigger airways of the lung, which gives us the conductive airways. And we also would require that they are willing and able to give written consent. So exclusion criteria include the below, and I don't really feel that it's necessary to go through all of that, but for just as a gist, we want to make sure that they are as healthy as possible, that they don't have any respiratory tract infections, because we want to be able to compare this data across many different times that they come in to do the lung function testing. And we also give them a period of smoking cessation at the screening visit. We also want to make sure that they haven't had any lung surgery. Again, we're looking at relatively healthy participants who don't have any lung or breathing related diseases. So at the first visit, we encourage all potential participants to cease smoking and provide smoking cessation advice using quitline information. We do give them a quitline pack, which gives them a diary to keep track of any kind of attempts they have at smoking cessation. We briefly discuss nicotine replacement therapy and pharmacotherapy that they can access information from their GP. We also make note of any kind of smoking cessation they've tried in the past, whether they've used pharmacotherapy or any kind of NRT, and we just keep track. So we also have these progress checks after the first visit between 2 to 6 weeks post-screening, and this is just to check in with the participant to see if they've attempted to, would need any extra help, or want more time to consider quitting. Now, participants that are unsuccessful in attempts to cease smoking, or that are uninterested in ceasing smoking, are invited for a second visit. So this is just a schematic of how the study runs. We have them come in for a screening visit. There's that 4 to 6 week period of smoking intervention. If they're successful at ceasing smoking, then we go ahead and exclude them from the study, because we do tell every participant that coming in and taking a look at what your lungs look like is great for you to know. And if there's no abnormalities at the moment, the best thing to do would be to quit smoking in order to prevent any onset of disease. Now, if they are unsuccessful or uninterested in quitting smoking, we do invite them in for a randomization visit, and this is where we provide them the study medication and follow them over the next 52 weeks. Now, the treatment phase includes, again, a placebo as well as the actual product. So in summary, this is it's an untested hypothesis. Again, it's a world first study for treatment of smokers, and it's quite important to look into this information. We also need a sensitive measure of eligibility, and we need to understand whether we can see or predict participants that are likely to develop smoking-related disease. It's also important that at the moment we have a less sensitive measure. Again, we need about 50% of the small airways to have been damaged in order to see a change in their FEV1 from their spirometry results. And that just isn't good enough. We need to use these clinical relevant secondary outcomes of small airways disease, and to make sure that we can catch these participants who might likely get some kind of smoking-related disease in the future, and to prevent that as that alleviates any kind of healthcare system with the participants overloading the healthcare system, as well as making sure that these participants understand how they can stay healthy even following quitting smoking. Now, this is a challenging study to recruit for, and that's mainly because all these participants are healthy. They don't have any kind of smoking-related illness and very little symptoms, if any at all. And so it's very hard to tell someone to come in and do some testing to look at their lungs unless they are actually interested in seeing whether they have already developed any kind of smoking-related illness. Now, I'd just like to thank a few people, and I'm happy to answer any questions you have after this. But a thank you to Professor Christine Jenkins, who recommended me to Renee to speak today. Thank you so much. And Cindy Tamron, who is my supervisor and the associate investigator at the Woolcock Institute of Medical Research, and the George Institute, which is the sponsor of this study through GSK. And finally, Renee, thank you so much for inviting me to speak to the tobacco treatment group.
Thank you so much. Thank you Thank you, Kevin, too, for hopefully getting us some questions up, Kevin. Hopefully this is working. And I don't see any at the moment, but yes. Well, I've got a couple of questions, if that's all right.
Yep.
First of all, for the edification of the audience, would you mind giving us a quick description of what the size of a small airway would be compared to a larger one? To the, in the scheme of anatomy, how small is a small airway, and when does it not a small airway?
Okay. So small airways, there's about, I want to say, maybe 24 generations of airways by the time we get to the small airways. And these small airways can be even as thin as a cell, so a cell around this airway. So just thinking of a cell thick one.
Whoa, that's in microns we're talking.
Yes, exactly.
Talking in sizes of microns. So these are very small, but they're still patent. They're still functioning little tubelets,
yes,
tiny tubelets. So this is important because if they block up, that does that whole area in, doesn't it? It blocks that whole area. So it's for our group who may not be from respiratory backgrounds that it's important to know at what point does that stop being a small airway and get it's right at the bottom of the lung, as it were, right at the end of the periphery. Thank you for that. So I'm not sure what we're asking Kevin to look at some more questions, but I have another one, and that's to do with DLCO. So I know what that is. That's the diffusion of the lung with carbon monoxide. Now, we all know, working in our area, that carbon monoxide is widely produced with smoke, and it there is a problem with measuring DLCO in smokers because they have carbon monoxide already on board. So do you always do a smoke-alyzer, a breathalyzer of carbon monoxide as a background?
No, we don't, but we do have all our participants stop smoking before they come in, and I know what you're going to ask. I may not be telling the truth, but we do make sure that it's one of the final tests.
Stop smoking,
so
like how?
They stop an hour before we tell them, and then they don't actually do the DLCO until about an hour and a half into the visit. So even if they had their cigarette right before walking in the door, at least we have that hour gap, which
there's a slow, as you know, what's the washout? It's slow. I'm only saying that because I'm a bit nervous about that, because of our smokers today tend to be heavily dependent. People who smoke today in the community, as we all know, are quite heavily dependent, extract a lot of from their cigarettes. So they tend to have high carbon monoxide readings to start with, which doesn't decay that quickly. So there's that's a little concern, a little matter. And the other matter that I'm sure you're all thinking of this too is our dope smokers, concomitant dope smokers. They're smoking something else as well.
Yeah, so they are excluded from the study.
Are they?
We only allow once weekly. And back to your point about the carbon monoxide being in a resident gas in their lung. We do have the washout again before that, and so they're breathing 100% oxygen for about 5 minutes, 3 times. So that should wash out all those gases prior to doing any DLCO. And then in between each trial, we wait for them to come back to the resident gas, which is nitrogen, roughly 80% nitrogen. So we do that about 3 or 4 times. So by the time they get to their DLCO, they should be
washed out.
Yes,
we hope so. We hope so. It's just a thought I had because of our patients having relatively high carboxyhemoglobins. Excuse me.
We do also correct for hemoglobin.
For hemoglobin, do you? Right. And I'm just curious to know, how high their hemoglobins can be.
They're actually all quite normal.
Quite normal?
Yeah. I've never really had a very high one.
Oh, because they're relatively young. Kevin, do we have any questions?
No, not at this stage. I just invited people to send in a question.
We haven't. Right. The other, I guess, pertinent point that came up, somebody asked me about some time ago already when we were looking and recruiting patients was, would this encourage people to continue to smoke?
Yeah.
That's you know, if you're well and you remain well, and you've got tests that show you're okay, because that doesn't preclude them from any other medical consequences of smoking. I know that, and you know that. But that does the patient or the person, the normal person, going away with everything perfectly normal, and here's a medication that will potentially keep me well because I'm a smoker? Is that
to be honest, I've had quite a lot of participants that have reduce the amount of cigarettes that they smoke over time. We've had a few that have actually quit during this trial as well. We do, I mean, I would never prevent someone from quitting smoking for this study.
Do you think the outcome might do that, do you think?
From what I've seen so far, I honestly believe that a lot of these people are kind of given a second chance to consider smoking. And because they've got a kind of longitudinal look at their lung function over time, they do feel like they're giving back to the scientific community, as well as understanding what kind of damage that smoking can cause.
The other point I don't know if you mentioned it was how old they are. What's the average age?
They're 25 to 55.
All right, so not all really young. No. They're not all really young. Well, that's interesting too.
As you know, not everyone will have a smoking-related disease. No, that's right. Some develop it earlier and some a bit later.
Yes.
I feel like there might have been
a question. Kevin?
No questions at this stage. You must have answered them all.
Oh, well, it would have been the obvious question to ask whether, gosh, are we going to have a medication that's going to make people feel better and be better? And that was, as I said, a question that came up quite a lot. Well, if there are no more questions, just a reminder for everybody who is logged on or who is going to watch this as a and I believe, Kevin, you have recorded this.
It is recording, and when you've given those instructions, I'll stop the recording.
Yes. When you do watch this as a recording, please indicate who you are and who else is watching it, please, to get your continuing medical education points through APSAD. We need to know, and we're starting to do that. Well, I'd like to really thank Tanya very much for her presentation. It's a very scientific presentation in terms of our respiratory function knowledge. Some obviously know more than others, but it's important to know that across the board with every smoking-relating topic, this is a really important topic because we're talking about the precursors of COPD, chronic obstructive pulmonary disease, and we need to remind and Tanya did that, our clients, our patients, that this is the most likely outcome of their smoking. And it's the greatest cause of hospitalisation and death worldwide. So we really need to remind ourselves to be on the ball and know about respiratory function if you're working in our field. So thank you very much, Tanya. Just want to announce that next time on the 26th of March 26th at midday, we'll be having Eliza Skelton presenting from the University of Newcastle, and she'll be presenting on her experiences with drug and alcohol patients again, very much on the grassroots experience. So we'll give you more information about that closer to the date. So thank you everybody for logging on, and thank you Kevin for hosting us. Kevin again and his team from the SDA, from the Seventh-day Adventist group. Thank you so very much. So goodbye everybody, and we'll see you next time, next March.